afternoon, everyone. Going to get started. My name is Bridget Burns. I'm the Senior PAR Specialist at the American Thoracic Society, the ATS. Welcome to the 11th installment in the 2020 Lung Disease Week at the ATS series and to Pulmonary Fibrosis Week at the ATS, which runs this week, September 20th through the 26th. The webinar today is entitled Symptom Management in Pulmonary Fibrosis and is being presented as part of Pulmonary Fibrosis Week educational programming. This program is a joint partnership between the American Thoracic Society and the Pulmonary Fibrosis Foundation. First, we need to inform you that the subject matter discussed here today is designed for educational purposes only. Therefore, you should not rely on this information as a substitute for personal medical attention, a substitute for direct medical care, or a substitute from diagnosis from a physician. If you need immediate medical help today, please consult your family's healthcare provider right away. Do not wait for a response from our members, staff, or partners. If you're properly logged into the webinar, you should be seeing my desktop and hearing my voice via your computer speakers. Some people may be dialing in with their telephone and should have been provided a toll-free number, access code, and an audio PIN. If you are dialing in with your phone, please turn down or turn off completely your computer speakers to avoid feedback. After the presentation, you may ask questions by clicking the question sign icon and typing a message into the chat box that pops up. The message comes to me and I'll relay the message to the presenter. Let's get started. First, I would like to acknowledge our partner, Ms. Jennifer Mefford of the Pulmonary Fibrosis Foundation and a member of the ATS Public Advisory Roundtable, PAR. Jennifer will also introduce our speaker today. Jennifer, welcome.
Thanks, Bridget. Appreciate it. And thank you all for joining us today. Like Bridget said, my name is Jennifer Mefford, and I'm the Senior Director of Corporate Partnerships at the Pulmonary Fibrosis Foundation. And I'd also like to acknowledge my colleague, Lindsay Bassett, who really helped coordinate this webinar as well today. So the PFF is a national nonprofit foundation with a mission to mobilize people and resources to provide access to high quality care and leads research for a cure so people with pulmonary fibrosis will live longer, healthier lives. We're really excited to have our speaker here today, Dr. Amy Hajari Case, who will be speaking about symptom management for pulmonary fibrosis. Thank you again, and please enjoy the webinar.
So I'll be talking today about symptom management in pulmonary fibrosis. And just to lay the groundwork, what I'll be talking about is a bit more general and not specific to any one type of pulmonary fibrosis. But there are common symptoms, and so we'll describe some of those and then talk about management strategies. I am one of the Senior Medical Advisors for the Pulmonary Fibrosis Foundation. I'm also an ILD specialist and researcher at Piedmont Healthcare in Atlanta. And as Courtney said, this is for educational purposes only. So if you have personal questions about your own healthcare, then of course it's important to consult your own personal physician. These are my disclosures. I do clinical research and I'm an investigator for several studies, as well as a speaker for Boehringer Ingelheim and Genentech. So just to get everybody on the same page, we'll talk about what is pulmonary fibrosis. So to the right here, you'll see an autopsy specimen of a lung that's been pretty significantly affected by pulmonary fibrosis. This is something we also refer to as interstitial lung disease. There's some subtle differences in that terminology, but most practitioners will use those terms interchangeably, and you'll see them written interchangeably in the literature oftentimes as well. Pulmonary fibrosis or interstitial lung disease can occur in well over 200 different types of very specific conditions. Some of those are limited only to the lungs. Some of them can be the effect of a systemic condition like an autoimmune problem like lupus or rheumatoid arthritis, in which the immune system can negatively impact the lungs. Can also be exposure related, and those exposures can be anything from the environment to occupations to things that we put in our bodies, such as medications or smoke inhalation. And this term pulmonary fibrosis essentially refers to the progressive scarring of the lung tissue, as opposed to when we think of asthma or COPD, where those diseases mostly affect the lung airways, the bronchial tubes that lead down to the lung tissue. The pulmonary fibrosis affects the spongy part of the lung tissue that is there to sort of soak up oxygen and get it into the bloodstream, into the rest of the body. this can lead to very stiff lungs, shortness of breath, low oxygen levels, among other symptoms. And you can imagine this lung here on the right wouldn't be squishy and spongy like a normal lung would be. I don't have a comparison photo here, but stiff and not very pliant and not very effective at doing its job. So what do pulmonary fibrosis patients actually experience? I hear a lot of complaints in my clinic about the symptoms that people have, but some of the common things are, they'll come in and they'll say, Doc, you know what? I feel great. I feel fine. My breathing is fine as long as I don't do anything, right? Or, Doc, I know you told me I need this oxygen, but the tank is just too heavy. It's a lot to carry around. I'm not sure if it's really the right thing for me. Or, if I would feel so much better if I could just get rid of this buggy cough that I have going on. Or I don't have any energy. I feel tired all the time. I need naps. And I hear this a lot too. I really just want to be able to interact with my family, do fun things with my grandkids, and be able to enjoy the things that I would otherwise be normally doing. So there are lots of pieces of pulmonary fibrosis. I'm sorry, this slide says IPF, but it really could be and should be labeled as PF. Pulmonary fibrosis is more, as opposed to the more specific diagnosis of IPF. But there are lots of impacts from pulmonary fibrosis to a patient's quality of life. And those can include symptoms like shortness of breath. We also use the term dyspnea. I'm going to use that several times. So dyspnea is a fancy medical word for shortness of breath. Cough, fatigue, and then the impact of having those problems or having a chronic medical condition on the rest of the body. So deconditioning or getting weak because of not utilizing the functional capacity that we have. Or even mental health impacts like depression and anxiety can negatively impact quality of life for patients with pulmonary fibrosis. And then when we add in there the effect of comorbidities, comorbidity is just another fancy medical word for other medical problems that we may have. Comorbidities, as well as medication side effects potentially. There are medications that we use for pulmonary fibrosis and medications that we use for other medical problems that can, maybe they're good for us, but they don't necessarily make us feel better. Let's talk first about one of the most common symptoms that we hear about in pulmonary fibrosis, which is shortness of breath. So this is almost universal in patients that have impact to their lung function. So why do patients with pulmonary fibrosis get short of breath? Well, we saw in that gross specimen a few slides ago, essentially what happens is you get remodeling of the lung tissue, the spongy part of the lung tissue, and the air sacs at the end of the bronchial tubes that are supposed to be there to exchange oxygen and carbon dioxide from the lungs into and out of the bloodstream that helps the body keep going. And so those spaces between the air sacs and the spongy lung tissue can get scarred and fibrotic, right? And thickened. And so there on the right, you see on that lower right hand picture, scarred interstitium. So interstitium is the spaces between things, the tissue part. And that area can get inflamed or scarred in pulmonary fibrosis. And the distance that the gas has to travel, the oxygen, carbon dioxide, primarily oxygen is the biggest problem here, to get into the bloodstream becomes more distant. And so that becomes more and more problematic as the disease itself progresses. And then the lungs themselves can actually become very stiff and non-compliant. And so that increases people's work of breathing. So when people are at rest, most of the time, most of us are born with more lung function than we generally use on a day-to-day basis. And so we can lose a fair amount of lung function before we're uncomfortable at rest. But when we get up to move around, our bodies need more gas exchange. They need more oxygen because our big muscles start to work and they're big gobblers of oxygen. And we need more ventilatory ability. So the lungs have to expand and move that air in and out. And the stiff lungs can't do that as well. And so we feel that and perceive that as shortness of breath. And this can become a really vicious cycle. So somebody with not normal lungs, respiratory impairment, right, functional dysfunction in the lungs can lead to shortness of breath with exertion, right? Not at rest, but with exertion. So I feel uncomfortable when I go to exercise. Here's my bear. He's exercising, he's up on his back legs, he's walking around, but he doesn't look super comfortable about it. So then he decides, you know what, I'm not gonna do that. I'm gonna take it a little more easy on myself because that's pretty uncomfortable for me. Well, then he gets to the point where he can't really do that type of exertion anymore. And then you see him looking like this, right? So he's short of breath now with even mild exercise. So he avoids it further, gets more weak, less functional, less able to do things. He loses capacity, and now he's short of breath with even little activity. So there are lots of factors that go into a patient feeling short of breath. It's not just oxygen levels, right? So there are patients who have shortness of breath without hypoxia, without low oxygen levels, even with exertion. But the stiff lungs can worsen shortness of breath, even in absence of an oxygen problem, before an oxygen problem develops. Pulmonary hypertension, which is a comorbid condition, so something that can develop in the setting of pulmonary fibrosis and complicate it, can make the gas exchange more difficult, can lead to worsening shortness of breath. Being overweight doesn't help. It doesn't necessarily negatively impact the lung function, but it increases the work that the body has to do. And so that leads to an imbalance of the effort to breathe and what we get out of it. Deconditioning, like our bear there, and then other comorbidities that can arthritis or muscle problems, things like that just make getting around more troublesome, can make shortness of breath worse. So lots of factors go into it. It's not just any one thing. So just because somebody is not hypoxic, or even if somebody is hypoxic, they're not feeling short of breath, that doesn't mean there's not a problem, okay? So how do we manage this? It is very challenging. So there's some things that we can do. If a person is hypoxic, has low oxygen levels, either at rest or with exertion, we want to supply some supplemental oxygen for that. Remember in the previous slide, we saw that there was a bigger distance when there's fibrosis in the interstitium. There's a larger distance for the oxygen to have to travel. So if we supply more oxygen, more of it can get across into the bloodstream and correct those low oxygen levels to the body. Pulmonary rehabilitation. So this is a structured exercise program. I'm going to talk a bit more about it in a minute. But you'll see that come up over and over as something that can be helpful for multiple symptoms in pulmonary fibrosis. I'm a big believer in pulmonary rehab. Sometimes something as simple as providing some better air circulation or fans can relieve dyspnea, at least acutely. So people might feel better, even if they're not necessarily functioning any better from a lung standpoint. All of us are in a situation right now where when we leave our houses, we're wearing masks, and that decreases the air circulation. It doesn't necessarily drop our oxygen levels or make our lungs dysfunctional, but we feel it. We feel stuffy. We feel, it feels harder to breathe sometimes. And when the opposite of that can add some air circulation or a fan, something, like I said, a very simple intervention can relieve dyspnea acutely. If shortness of breath is triggering anxiety or vice versa, anxiety is triggering shortness of breath, treatment of anxiety can actually help some of that. It doesn't fix the underlying problem, but it can help the symptom, and it can help stop some of the cycle. If you feel like you can't breathe, it's certainly anxiety provoking. And if that becomes pathological, your doctor may recommend something to treat the anxiety. And then sometimes, as part of a palliative regimen or a symptom management regimen, use of opiates or narcotics can be helpful, but this is not something that providers generally go to very early in the course. We do a lot of these other things first as part of treatment and management of shortness of breath, but that can cut down on the symptom of shortness of breath when things are more advanced. So I spoke about this, but if oxygen levels are low, use oxygen when they are low. It is not convenient. I have to admit that. but it is something that can be helpful, particularly for the symptom of shortness of breath if it's there. What does oxygen use do in pulmonary fibrosis? Well, it can decrease, maybe not eliminate, but it can decrease. It can eliminate in some people or prevent some of the shortness of breath. And what we want to think about doing is adding the oxygen to our systems before low oxygen levels happen. So it's a misconception that the lungs act like a gas tank and can be filled up with oxygen. I can take my oxygen off and go do what I need to do. Then I get short of breath, I must be out of oxygen again. And then I'm going to come back, fill up again and go. Actually, it doesn't work that way. What we really need to be doing is supplying the oxygen to the system during the activity, during the activity where the body needs more oxygen, because that's supplying what we need and can prevent some of the shortness of breath that happens and maintain the level of activity and functional status rather than losing it like our bear in the cycle. It can decrease the risk of pulmonary hypertension. So having low oxygen levels can potentially increase the risk of pulmonary hypertension, a complication of pulmonary fibrosis, where the pressures in the lung circulation and on the right side of the heart go up. And that's something we don't want to have. So we want to decrease that risk if possible. Can lower the heart rate. So if your heart's having to work extra hard, if you've got not enough oxygen in the system, well, then the heart says, I guess I've got to circulate that blood more quickly to get more oxygen around. And then the heart rate can go up. So if you're noticing that's happening, sometimes adding extra oxygen can keep the heart rate from jacking up with less activity. Can help people increase their activity levels. So there are times when people are really trying to exercise, trying to keep their functional status up, keep those muscles going, and they're limited by their oxygen levels. Well, adding supplemental oxygen during those times can help people increase their activity levels, and it can improve quality of sleep if there's hypoxia or low oxygen levels during sleep. So I'm admitting it right now, it's not necessarily as convenient as these pictures make it look, but there are lots of options out there, and I would strongly recommend talking with your provider, your respiratory therapist, your DME company about what option meets your needs the best and is accessible to you if there's something that isn't working about the situation that you have. So this is Dr. Tom Petty. He actually wrote a wonderful little book called Adventures of an Oxyphile. And I put this here to dispel another myth that oxygen is addictive. We are all addicted to oxygen. Everybody who's listening to this today, unless you are a plant, you are breathing oxygen. Okay, plants breathe carbon dioxide, we breathe oxygen. And so we're all addicted to it. It's just some of us need more supplied to us than others because of limitations in the lungs. Using oxygen will not drive an increased need for more oxygen. The need for oxygen is part of the lung process itself and is not made worse by use of supplemental oxygen. It is not addictive. You're already addicted. So changing gears to that other thing I told you I was going to talk about and bring up probably several times here is pulmonary rehabilitation. Look at these people and how happy they look in their pulmonary rehabilitation classes. So pulmonary rehabilitation or pulmonary rehab is a structured exercise program. There are components of that, of aerobic exercise, of light weights or bands and strengthening that go into a program like this. And there are educational components that help people learn about their lung process and things that they can do to be stronger, better, more functional, and in a group setting. And so it is something that can be helpful for people with pulmonary fibrosis. Here's some of the components here. So we talk about exercise training, some outcomes assessment. So how did you do? How did it help you? Training of the respiratory muscles and some controlled breathing exercises, psychosocial support, evaluation, nutrition evaluation and counseling can be available to people if they wish to avail themselves of that, to try and get, just more elements of a healthy lifestyle. And like I said, education about their lung disease process, ways that they can live a healthy lifestyle, ways that they can make their oxygen work for them, and so on, as well as the training and education in those exercises. Usually pulmonary rehab is a set, defined number of sessions, and we want people to be able to continue that exercise once their sessions are all completed and take those things that they have learned and continue to use them and continue to work toward their goals and maintain their functional capacity that they've gained during the program. So oftentimes people will graduate from a pulmonary rehabilitation program into a next phase program, or even to something in the community like a Silver Sneakers program or something at a local fitness center or health center. And this is just another illustration of what can happen when this, again, says idiopathic pulmonary fibrosis, which is what this article was written about, but it really applies to people with all types of pulmonary fibrosis or pulmonary limitations. But the restrictions, so the stiffness of the lungs, the impaired gas exchange, or the trouble getting oxygen around, can lead to shortness of breath, fast breathing, and then that leads to anxiety, some decreased exercise capacity, people being less active. So again, this is that vicious cycle just demonstrated in another way. And the fact is that pulmonary rehab can start to reverse some of those things and improve conditioning, increase physical activity, improve the social participation, decrease the anxiety, help people feel in more control, less fatigued. And, you know, I've said this multiple times to my patients, lungs aren't muscles, and no amount of exercise is going to make the intrinsic function of the lung better. But the rest of you is a lot of muscle, okay? So you've got respiratory muscles and core muscles that hold us up, and big muscles in our lower extremities, our legs and our arms when we lift. And those muscles use a lot of respiratory function. So they need a lot from our lungs to do their job. And if they are inefficient because they're not well conditioned, then using them can cause a lot more shortness of breath than if those muscles are more efficient and better conditioned. So it's the difference between like my husband's Mustang with a giant engine and, you know, gas guzzler, right? Or my fuel efficient Audi that I drive, right? So, you know, it's or a hybrid or something, I don't know. But essentially what you're trying to get to is a more efficient machine with the same amount of lung function that gets you to what the activities that you want to do. And pulmonary rehab can help you get there. So what are the benefits? So better exercise capacity, less symptoms, particularly shortness of breath, but it's going to affect other symptoms that come up with pulmonary fibrosis as well, more energy, better stamina, better quality of life, and some self-management skills as part of that educational process as well. All right, here we go. Cough. If shortness of breath is number one, cough is number two, and they could sometimes jockey for first place as far as problems that people have related to their pulmonary fibrosis. I don't know how many times in a week I hear, you know what, I actually feel pretty good, but if I could just get rid of this darn cough. I cough all the time. People think I'm sick. I just can't get rid of it. And then how do we make this better? All right, so why do patients with pulmonary fibrosis cough? If I were going to be really mean, I would just leave this up here and try and let y'all interpret it for yourselves. But I'm going to simplify it, okay? So this is a lung. This is a left lung here, right? And if I have a pointer, there we go. So left lung. These are airways here, and this is representing nerves and nerve endings that feed up to the brain stem and the brain, okay? And the output here being cough. So here, this is talking about normal triggers for cough, things that would make a normal person cough, cause cough in pulmonary fibrosis patients as well, whether that's reflux with aspiration or postnasal drip, allergies, concomitant asthma, things like that that are normal triggers for cough. People with pulmonary fibrosis are just more sensitive to those things. So if a person with pulmonary fibrosis starts coughing, they cough longer, they cough more times, they have more trouble getting that cough back under control than a person who has normal lungs without pulmonary fibrosis. Now, it turns out pulmonary fibrosis patients have double whammies. They also have specific triggers for cough, and that includes changes to the airways. So traction bronchiectasis pulls the airways because of the fibrosis around the airways, pulls them wider and can cause some changes in the mucus itself, as well as the stiffness and fibrosis in the lungs can be a trigger for pulmonary fibrosis patients to cough too. So these are inputs in the lungs, the things that the lungs are sensing and are triggering the nerves to cause a cough. So that goes up to the brain and makes the output is that we cough. So what are causes of chronic cough that are not pulmonary fibrosis? Okay, so what are the things that a doctor is thinking about when a patient comes in and says, man, I've been coughing for a really long time. It's been more than 6 months and I can't stop coughing. What are the top bunch of things that I'm going to look for outside of pulmonary fibrosis? Well, I'm going to think about these types of things. Asthma, even undiagnosed asthma or cough variant asthma or some type of airway sensitivity. Maybe in the case of pulmonary fibrosis, we can also have other types of airways disease like concomitant COPD. Some people have combined pulmonary fibrosis and emphysema, so airways, other lung problems. Postnasal drip. I live in Georgia, and I tell you what, we don't have real winter here, so nothing ever dies, and there's lots of allergens around, and there is lots of postnasal drip where I live. So that's something to think about, and it can trigger a cough, right? So something that's dripping to the back of the throat can cause a cough. But the problem is with pulmonary fibrosis, somebody starts coughing, they can't stop, okay? Allergies, seasonally, maybe we notice that, or other parts of the environment. There are medications. Particularly, we look first for a medication class called ACE inhibitors that are blood pressure control medications that are notorious for causing people to have a dry cough. And if the timeline is that the cough started at the same time as this ACE inhibitor medicine started, well, it might behoove that patient to have a different blood pressure medicine substituted to see if the cough does get better, okay? Smoking or any other inhalational irritant, so smoking cigarettes or smoking cannabis, anything that we're inhaling into our lungs that shouldn't be there can cause people to cough. And acid reflux. So if you've got a lot of acid in the stomach that refluxes up into the esophagus and is burning, giving heartburn, well, that itself can trigger cough. If that comes up into the back of the throat, one can really imagine where the nerves that sense that in the back of the throat and cause cough can get irritated and could cause cough too. So there are patients that have acid reflux that don't necessarily get typical symptoms of acid reflux like heartburn or indigestion, but they cough as a result of that. And so that can trigger cough as well. So we have to think about all of these things in addition to the pulmonary fibrosis being a problem, because all of these are very common. So how do we manage cough when we think about pulmonary fibrosis? Well, first of all, we want to think about other causes. If there's anything that we can do that is manageable in a way that can stop the trigger, that is going to be much more effective than really trying to just put a Band-Aid on the symptom. Okay, so if people have reflux symptoms that are untreated, we have reflux that's happening, we should treat that. Allergies, drainage, sinus congestion, there are ways to manage that, antihistamines, decongestants, things like that. If there is airways disease, asthma, or COPD, then sometimes inhaled medications can be helpful. And then, we always want to think about if a cough is new or changed. That's something that your doctor wants to know. Same thing with shortness of breath. But if that's a symptom that is new or changed, we want to investigate that as something maybe infectious, get some new imaging, talk about why that's happening. And if it's, if it is not, I wouldn't just assume that it's disease progression or just assume that it's the pulmonary fibrosis, but investigate that a little bit further to know before we assume that we should just be using cough suppressants, things like that. Now, if we've done all of our due diligence in that way, we want to think about targeting the cough reflex itself, right? That big arrow that was leading from the trigger up the nerves and into the brainstem, and then causing back down to cause the cough. So non-specific cough suppressants, guaifenesin is something that's over the counter, has some variable success with patients with pulmonary fibrosis. Benzonatate is by prescription, it's not narcotic. Some people find that helpful. These are hit or miss, but it's worth trying, okay? Because you might be one of those people for whom it is helpful. Sometimes we resort to a low-dose steroid. And without getting into the specific management of the hundreds of kinds of pulmonary fibrosis that exist, sometimes steroids are part of that chronic management of the disease outside of cough, and sometimes steroids are not indicated for treatment of the disease itself because they don't necessarily change the way the lung function changes or make things better, but can, in this case, in the right patient population, control the symptom of cough. And I think we have to understand the difference in those specific scenarios. Gabapentin is a medication that is a nerve medication. Remember, we're talking about targeting the cough reflex. That can be helpful. That's something that is a decision is made on an individual basis, whether that is the right thing for you. And sometimes opiates, so narcotic cough medicines, cough syrups, prescriptions that contain narcotic medications can successfully control cough, and particularly situational or at times when things are a little bit worse. I want to think about doing that. So I'm going to talk a little bit about reflux, gastroesophageal reflux disease. So again, the acid, the fire in the belly that can come up and cause problems in the esophagus. It's burning, it hurts, it doesn't feel good. You can sometimes feel that in the back of the throat. Now, it's not just cough. There is some evidence that if reflux exists, it can worsen lung function over time and can cause recurrent injury. Remember that stomach acid is there to digest your food, okay? It breaks stuff down. And if that gets into our lung tissue, which is spongy and very delicate, can that not, you can imagine how that could cause some injury, even on a microscopic scale. And if one is predisposed to scarring and pulmonary fibrosis or inflammation in the lungs, then over time, then that could lead to clinical worsening of the lung process itself. So, so with or without cough, this may be something that if it's present and your doctor thinks that it is possibly driving the process, then treating it might be of benefit. And there's some evidence to the fact that taking an acid-reducing medicine may change the course of pulmonary function decline. So here we see the forced vital capacity. FVC is a lung function measure on the y-axis, and then on the left x-axis is our time. We see patients that are taking PPI and H2 blockers or acid-reducing medicines. That those taking that have, in this particular population study, showed less decline in their lung function as those that were not taking acid-reducing medicines. This is circumstantial evidence, but we do think that in the right patient, if there is reflux, treating it might be helpful. And this was in an IPF population, so that's why it does say in this case, as an example, IPF. This is another study showing that patients who had, this was in this case, surgical intervention, which we're not sure necessarily that that's the right way to control reflux, but it is a way to control reflux in people who have indication to do so. So patients who either did or did not have a surgical intervention for their reflux, a WRAP procedure, the patients who did not have that type of control actually did a bit worse in this particular WRAP-IPF study. And again, this is an IPF population. So again, not pertinent to cough necessarily, but outcomes in disease. There are some clinical trials, some that are completed and some ongoing, for cough and pulmonary fibrosis. I don't have a lot of updates here, but just some things to be looking out for. I'm not sure if you guys are hearing my computer make a binging noise, and I apologize if you can hear that. I don't know what's making it. Thalidomide was shown in a small randomized controlled trial several years ago to decrease the cough and improve quality of life, probably related to cough, in patients with idiopathic pulmonary fibrosis. This is not something that we typically use for cough control, because we do have other things that can be helpful. And this, thalidomide is not an easy thing to get our hands on. It has some teratogenicity, or there were sorry, not that. It was so it was used many years ago and had limb defects in pregnant mothers or children had problems. So it is something that we don't use lightly, but it is something that has been shown to be helpful in a small randomized controlled trial. The scenic study is looking at a medicine that has letters and numbers to it. I don't know that necessarily has a name yet. That's been ongoing, closed to enrollment earlier this year, but was specifically looking at cough control in patients with pulmonary fibrosis. And then gefapixant is a medication that is under development for use in chronic cough and has been studied in IPF. That study is closed and there aren't any results published at this point, but that's another medicine that could potentially be of use if it is ultimately available. Again, still investigational at this point. So to switch gears, talk a little bit about fatigue. This is, I think, number 3 on the list of top problems that people with pulmonary fibrosis struggle with. Fatigue, or just lack of energy, the feeling that they run out of gas or the batteries are down. They have the energy to do a little bit, but not as much as they used to. So what causes fatigue in pulmonary fibrosis? Wow. So there's a lot that goes into the level of energy that we have, and some of these things are going to look familiar, right? So the pulmonary fibrosis itself can be associated with fatigue. The underlying issue that causes, if it's a systemic problem, like an autoimmune problem or something like that causes pulmonary fibrosis, that in and of itself can be associated with fatigue. But pulmonary fibrosis is known to be associated with fatigue as well. Low oxygen levels, either during the day with activity or at night with sleep. Even an absence of sleep apnea can certainly lead to fatigue because it disrupts sleep and causes people not to rest well, even if they don't realize it. Sleep apnea is a common medical problem in patients with pulmonary fibrosis. And people with sleep apnea with pulmonary fibrosis may not have typical symptoms of loud snoring and waking up all the time. People may say, I feel like I sleep all night, I sleep well, but when you test them, they may actually have sleep apnea or low oxygen levels, if not sleep apnea at night. And so we may have to have some different thresholds for testing people for sleep apnea. Treating that may improve people's level of fatigue as it improves their sleep. Deconditioning, again, so the vicious cycle with muscle weakness, physical inactivity can lead in and of itself to fatigue. The psychological or social stressors, people are living in the real world. So with or without pulmonary fibrosis, we all have times of psychological or social stress, and that can compound our level of fatigue. Anxiety or depression, either related to chronic medical illness or independent of chronic medical illness, can lead to fatigue. Medical comorbidities, pulmonary hypertension, or other medical problems that people have that are unrelated to pulmonary fibrosis can also compound fatigue, make life harder and more tiring. Medication side effects. So some of the medications that we use for pulmonary fibrosis can cause fatigue, or medications that we use for other medical problems can lead to fatigue and tiredness. Or, ironically, excessive caffeine or alcohol intake can cause fatigue if it's disrupting our sleep or disrupting our level of awakeness. So how do we manage this energy level and fatigue in pulmonary fibrosis? Well, I'm not going to show you all the slides again, but pulmonary rehabilitation and really reversing the vicious cycle as much as possible can help with people's level of energy. We want to use oxygen if a person is hypoxic, and use it when the oxygen levels are low. Remember I said the lungs are not a gas tank. And so we need to have the oxygen applied during the times of low oxygen, if that's at night or during the day or both. That may be something that needs to be attended to. And we also have to be thoughtful as doctors and medical providers that just because we checked oxygen levels at rest when we got vital signs in our clinic, what's happening to those oxygen levels with exertion? What is happening to those oxygen levels at night when people are sleeping? If they're having fatigue, or should we be looking to see if their oxygen levels are going down and perhaps causing some of that problem? We need to look for the underlying causes and complicating factors. So we need to think about the presence of sleep apnea. We need to think about other medical problems that maybe haven't been diagnosed. Is the person anemic? Do they have thyroid disease that's developed? Are they depressed, feeling anxious? Other types of things that maybe we don't think about because we're assuming that fatigue and tiredness is just part and parcel of having pulmonary fibrosis. So we don't want to forget that a patient is a whole person. All right, so a little bit on sleep apnea. So we need to look for sleep apnea and treat it if it's there. So obstructive sleep apnea is actually really common. We have the best data in idiopathic pulmonary fibrosis, so we're going to see some of that here, but not to be discounted for other types of pulmonary fibrosis, because some of the physiology can be similar. We should think about that as well. In one cohort that Lisa Lancaster published now more than 10 years ago, in patients with IPF, the vast majority of them had some type of obstructive sleep apnea. More than 50% of them had moderate to severe sleep apnea. And again, here 12% only had no sleep apnea at all. This is some more recent data that shows that the oxygen levels at night really can be low, out of proportion to what we would think. You know, I've had patients say, you know what, I'm fine when I'm exerting myself, so I don't need oxygen then. So why would I need it when I'm asleep and I'm at rest and I'm not doing anything? Why would my oxygen levels aren't going to go down? But the brain, even with normal lungs, the brain resets itself at night, and there are other factors at play that are not exertional that can lower oxygen levels. So more shallow breathing, the state of sleep that we're in, things like that. And then obstruction. So when the throat closes, you hear that snoring sound and it closes off, that can decrease the ventilation. And so sleep disordered breathing can impact oxygen levels at night, which in turn can impact the quality and type of sleep that we're getting and can lead to fatigue during the day. And just because a person can exercise with oxygen levels that are okay during the day does not necessarily mean that at night everything's hunky-dory. So we need to have some threshold for thinking about that. So the symptoms of sleep apnea are here, but I will go ahead and tell you that patients with pulmonary fibrosis don't necessarily have all of the typical symptoms. They're not necessarily going to check all of these boxes here. And the tools that we usually use to screen for sleep apnea by symptoms actually don't perform very well for patients with pulmonary fibrosis. So we might want to have a little bit different threshold for checking levels, for doing a sleep study, for asking more probing questions about how we're feeling and thinking a little differently about fatigue as an isolated symptom. If it is untreated, sleep apnea may actually worsen survival in pulmonary fibrosis. So it is important. It impacts pulmonary fibrosis, but also in fact impacts a lot of other medical problems, particularly cardiac, neurological, can worsen trouble with high blood pressure and blood glucose control too. So very important to treat. And really, we cannot necessarily make the diagnosis clinically or quite know how to treat it. We need a sleep study to diagnose this. And whether that is a home sleep test or an in-lab test where you spend the night in a sleep lab hooked up to all the monitors and things like that, is really up to your medical provider to decide what is the best option. But that sleep study is really important for diagnosing the problem, assessing the level of severity, and helping the sleep specialist to know how best to treat that problem. Because there are different treatment options depending on the level of severity and the actual diagnosis of sleep apnea. The mainstay of treatment is CPAP, but there are, like I said, other ways to treat this depending on what's going on in the patient and how severe it is. So that's something you would want to get with a sleep specialist about how to manage. So depression and anxiety. These are mental health impacts of pulmonary fibrosis and really can be seen in any chronic debilitating illness. But depression and anxiety are actually pretty common. And so, there is some overlap even outside of sort of the situational existence in pulmonary fibrosis. So ways to treat and manage depression and anxiety in pulmonary fibrosis. We think about psychological support, so psychotherapy or talk therapy, talking with a psychologist, right? Be that in a group or family therapy. Cognitive behavioral therapy is a way of a specific type of therapy that take our thoughts and our perceptions, change our behaviors and how we respond to them, and that can actually be very beneficial with depression and anxiety. Support groups, so I'll talk in a minute about support group availability, but talking with people who have like struggles and understanding how they have gone through it and knowing one is not alone, and being educated. So I remember back to like Saturday morning television when I was a kid, knowledge is power. So empowering oneself that one is not alone and learning more about how to take control and manage their illness can be helpful to people. And then there are medications that a primary care doctor or a psychiatrist, providers in our pulmonary fibrosis care centers might choose to employ. Antidepressant medications can be helpful with both depression and anxiety. There's some overlap in that management. And then medications that directly address anxiety or panic disorders. I'm going to give you a little bit of a word here on palliative care. So palliative care gets a bad rap as a terminology, as a term, but really it's because people assume that it is hospice. It is not that there's anything wrong with hospice, because in the right patient, it is completely appropriate and can be very beneficial. But when a provider mentions palliative care, it doesn't mean the end is absolutely near. Palliative care is really addressing the care that a person needs in terms of symptom management and focusing on quality of care at the right time and in the right place. And so hospice is a very specific type of palliative care that's delivered at end of life. But palliative care or symptom-based care can really overlap with both curative and disease-specific treatments. So things that are intended to prolong life can be used at the same time as symptom management. They are not mutually exclusive. And so as we talk about progressive chronic disease, we can talk about that on a bit of a continuum. So when a person is early with minimal symptoms with that chronic illness, maybe palliative care symptom management is not top of mind. There's not as much to manage. There's not as many symptoms. But as disease progresses, we start thinking about patients become more impacted by those chronic conditions, by those symptoms, by frequent complications, potentially hospitalizations and things like that. And that's when symptom management or palliation kind of takes over a bit, and the curative intent or the life prolonging intent gives way to the importance of quality of life. And at the end of that, at the nearer to the end of life, where supportive care and symptom management and quality of life become paramount is when hospice is most appropriate. So there are lots of symptoms and lots of factors that impact the quality of life in pulmonary fibrosis patients. There are others, but this is kind of the frequent offenders list and some strategies to manage those things. So just to recap here, with shortness of breath, fancy word dyspnea, we want to make sure that we're not missing new comorbidities, other medical problems, or complications that have arisen. We can apply supplemental oxygen if that's appropriate, utilize pulmonary rehabilitation, sometimes medications just to blunt the shortness of breath as a symptom like opioids can be helpful. Similarly, for cough, we want to treat any underlying conditions and can use non-specific cough suppressants. For fatigue and deconditioning, again, the job here is to not assume that symptoms are entirely related to pulmonary fibrosis, but that there may be other problems happening, and that we want to make sure that if something is new or changed, significantly worsened, that we're not missing something like a sleep apnea or a cardiac condition. If it's safe, pulmonary rehabilitation, again, can be very helpful, improving people's energy level, their physical conditioning, and again, supplemental oxygen. And then with anxiety and depression, behavioral health, talk therapy, support groups, and medication therapies can be very helpful if appropriate. So what are some ways, knowledge is power, we can get informed? The Pulmonary Fibrosis Foundation is here for patients and caregivers and providers to help provide education and information. There are a number of support groups. So on the PFF website, there is a listing of active support groups in the time of COVID. I'm surprised it's the first time I've actually mentioned this in an hour. But as we are living in a global pandemic, most of our support groups, even the local ones, are online, and so they're meeting virtually. They are still meeting. You can connect with somebody locally or nearby. There's also a telephone-based support group, as well as a support group specifically for caregivers that is virtual. You can find out about at our website. There's our patient communication center, so can call or email in with questions, looking for resources, things like that. Certainly the American Thoracic Society, the Chest Foundation, and Rare Connect are wonderful resources for information about pulmonary fibrosis. And that is all the content I have for today. And we do have a few minutes. Courtney, I know you said you were gonna bring some questions, but I would thank you guys for having me. And I'm happy to take a few questions before the end of the hour.
Thank you so much, Dr. Hajari Case. We do have a few questions. One of the questions we've been getting a lot is about the slides. This webinar has been recorded and it will be posted on our website in about a week's time. So if you check back on our website, then you'll have access to the video and slides. So we only have time for a couple of questions, but our first question is from Bill. And he says, I am on O2 therapy, 3 LPM, and when I move around, my O2 level falls into the low 80s or even 70s. When I notice it's that low, I stop what I'm doing and wait until my O2 level rises back to at least 90. My question is, these are routine episodes of low O2 levels. Are they doing any damage to my heart or brain, etc.?
That is a really good question. And I think we don't fully understand the impact of hypoxia or low oxygen levels intermittently for short periods of time, and what that does to the body. Chronically, right? One could postulate that if there are times, even little bits at a time, where the body is not getting what it needs, then over time that could potentially lead to problems with, as you mentioned, the chronic users of oxygen, your heart, brain, other organs. But there's not necessarily a lot of data to support what actually happens during those episodes. I would say that there may be an opportunity, and I would encourage you to talk with your physician about whether it would be appropriate to increase the oxygen flow for specific activities during which there are known to be low oxygen levels, so that the activity that you're doing is not limited by frequent stops. And if you remember back to the slide with the bear, you run into trouble and you stop doing what you're doing. Well, the next time you go to do that thing, you might be less able to do it. And so that may be something just to consider, whether that would be safe and appropriate.
Thank you so much. Our next question is from Francis, and they ask, how do we participate in pulmonary rehab under COVID conditions, and are there any guidelines?
Yeah, so there are some statements out there. I believe the ATS has a statement about the operation side of pulmonary rehab, so more geared towards the providers that are hosting those classes. I would say that I would inquire of the center that you're considering participating with about what they're doing in terms of COVID safety. There are programs back in the spring. Most pulmonary rehab programs were closed, as were many of our medical centers for anything that was optional or non-emergent. And certainly pulmonary rehab, while important, is not an emergent or urgent therapy. So, but now many of those facilities are open and they are taking patients into their programs. And the factors that we think about in terms of COVID risk mitigation, remember, nothing in the pandemic world is without risk unless you are at home with your own immediate family members and nobody goes anywhere. Anytime you leave the house, there is exposure risk associated with that. But when we think about the types of things that increase risk, we would be thinking about large crowds, small indoor spaces that are poorly ventilated, and no mask wearing. So things that can improve the safety of and decrease the risk of exposure in those types of environments are limiting class size, keeping a consistent group of people so that the exposure is the same, making sure that the people are able to space apart in the facility at any given time. And when they're not actively exercising, perhaps in an educational setting, that they are wearing masks universally. And also thinking about the ventilation and air turnover in the facility as well. Now, alternatively, there are some there may be online resources that your center may offer, so some educational types of things that you could do either online or by, say, like a DVD or something like that, that is not quite the same as an in-person experience, but can be beneficial at least getting people moving in their own environment and doing some of those similar activities. There's not a lot of magic about being in pulmonary rehab. It's more I shouldn't say that, it's definitely magical, but the space itself is not magic. It's the activity and the education and what we take away from that to improve our own our functional capacity. So so in terms of being able to do some online participation or recorded sessions could certainly be of benefit.
Thank you so much. We're running to the top of the hour, so unfortunately we don't have any more time for questions. I know we do have a lot of questions we were unable to answer. However, I will send those off to Dr. Hajari Case and Jennifer Mefford over at the PF Foundation so we can get those answered for you. I just want to thank you, Dr. Hajari Case, for this wonderful and informative presentation and for taking your time today to come speak with us. Jennifer, do you have any closing remarks for us?
No, just thank you very much for attending the webinar, and please, yes, let us know if you have additional questions.
Thank you. And Dr. Hajari Case, do you have any closing remarks?
I would just thank you for having me, and thanks, Jennifer, for being here also.
All right, thank you so much, everyone who was able to join us today. Again, this webinar has been recorded and will be posted on our website in about a week's time. And have a wonderful afternoon, everyone.